Okay, so this would be, medical level, medical student level ECG introduction. Okay, we hopefully will be done in 1 hour, and so that you guys, do have time for doing other stuff. Okay, so I will start with an example. Okay, so please, anyone, please just volunteer and try to read this ECG. It's not tricky, it's an easy ECG. Anyone?
I can start.
يلا تفضل.
So this is I do check the name and the age of the patient who was taking for, and
Okay.
then I'll
So the
comment on.
Is young at like 18. Okay?
18. Okay. Then I'll check the rate, the rhythm. The rate is a P wave before every QRS, and then 1, 2, 3, 4, 5, 6, 7, 8. So rate is around 66, or 70 mentioned, and then check the PR interval.
Okay.
No, I think it's normal. It's not clear because I debate.
Clear. Now it's clearer.
Yes.
Okay.
Okay. So.
Okay. So
then it looks regular.
Okay.
Can you comment on the axis as well?
Okay.
Axis T1 and ABF is normal axis.
Okay.
And you can calculate the corrected QTC.
Okay.
By taking the QT interval divided by the square root of RR interval.
Okay. Which in this case would be normal. Okay. Anything else? So normal ECG?
Yes.
Okay.
We also have to comment on the paper speed and the calibration.
Yeah. Right. Okay, good. So, I'll come back to this ECG, but, the PR is definitely generous. Okay, the PR is on the higher side. It's around 200 millisecond, which is by definition first degree AV block. Okay, but good. So you need to have a system in order to interpret an ECG, like an X-ray, right? X-ray, like people will teach you how to approach a chest X-ray, going from lateral to medial or superior, or, superior to inferior, and so forth. Same thing for an ECG. You need to have a system so that you don't miss anything. Okay. So. So in order to have you can, there are so many systems, but everyone should have his own system. Okay. So by the way, anything bold here, it's important to know, and anything that is shaded is a little bit advanced level. So it may not be super important for examination purposes, but it's good for you, of course, for general knowledge. Okay. So back to approaching the ECG. First of all, like you said, you need to know, of course, the ECG is the name, the name on the ECG, and this is the ECG that you're interested in for that specific patient. So you want to make sure, the name is appropriate, and you want to examine patient Ahmed, and this ECG is for patient Ahmed, not for someone else, right? So name is important. And then age, because depending on the age, numbers, normal values differ. Okay. And then next is like what, one of you guys said, the calibration signal and the paper speed is important, because of course, if they are different, then the ECG would look different, and then you may over-interpret the ECG. So calibration signal, you will see like a rectangular box at any edge of the ECG. Usually it should be 10 small squares in height. Okay, so which means each millivolt would produce a signal of 10 millimeter in height. Okay, 10 small squares in height, which is standard scale. However, sometimes you see nurses, whether intentionally or not, they may print out an ECG with half standard. Okay, so this would make the ECG look different, and then so you have to pay attention to this. Plus the paper speed. There's a normal, or the usual paper speed is at 25 millimeter per second. Sometimes it changes, and then if it changes, the ECG would look different, and then you may overinterpret an ECG. But it looks abnormal just because of the paper speed. Okay, so pay attention to the paper speed and the calibration signal. Okay, and then next thing you think of is rhythm. Okay, so whether the patient is in sinus rhythm or not. Do you guys know how would you know whether a patient is in sinus rhythm?
There's a P wave proceeding every QRS.
Okay. Anything else?
The P wave should be normal.
Okay, good. What do you mean the P wave should be normal?
3 small boxes wide and 2 small boxes.
Okay. It should not be wide. Should be trying to, right? Okay. Anything else?
P wave has to be positive and lead through and biphasic in V1.
Okay. So the P wave should be, in other words, the P wave. There's something called P wave axis, and if you remember that the sinus node is located at your right upper atrium. Okay, right atrium on the upper side, where the SVC and right atrial appendage communicate, or like in the area in between the right atrial appendage and the SVC. Okay, so this is where the sinus node is located. Okay, and the electrical activation starts from the sinus node, of course, and travels, elsewhere, right? So the electrical activation goes from right top to, from top to bottom, from right to left. Agree? Right? So,
Yes.
So it goes from top to bottom. You see my mouse, right? My arrow, right? Do you guys see me here? You see my arrow here, or you don't see my arrow?
We
No, we don't see it.
Don't see it.
Okay, interesting. I don't know why. Okay, let me use a laser. Do you see it now?
Yes.
Yeah?
Yes.
Okay. So this is the sinus node, right? So the sinus node is at the right, upper right atrium on the upper side, and the electrical activation travels from the SA node towards the AV node, from top to bottom, and from right to left. Okay? So in other words, inferior leads should have positive P wave because the electrical activation is going towards the inferior leads, right? And the left leads should have a positive P wave because the electrical activation is going towards the left leads. Make sense?
Yes.
Yes.
Okay. So in other words, sinus rhythm, the definition of sinus rhythm is when you have a normal P wave axis. In other words, positive P waves in the inferior leads, 2, 3 AVF, and in the left leads, lead 1 and AVR. Okay? So in this case, this patient has a positive P wave in lead 1, 2, 3 AVF and AVL, and negative in AVR because AVR is a right-sided lead and you're going away from the right side, so you have a negative P wave. Okay, so this is normal sinus rhythm. Make sense?
Yes.
Okay. The morphology of the P wave, someone said it's wide or tall. This only indicates whether the right atrium or left atrium is enlarged or not, but it doesn't mean that doesn't help you in terms of whether the patient is in sinus or not. The axis of the P wave is what determines whether the patient is in sinus rhythm or not. Okay, so if you have a big P wave, but still positive in lead 2, 3 AVF and lead 1 and AVL, this is still sinus rhythm. Okay, make sense?
Yes.
Yes.
Okay, and also if you have, let's say you have someone with complete heart block where you have so many P waves without QRSs, but the P waves are still normal in axis, then the patient is still in sinus rhythm. So you don't need P, QRS, and P, QRS following P, and QRS preceding a P wave to define sinus rhythm. Okay, sinus rhythm just means the electrical activation starting from the sinus, and hence you should have a normal P wave axis. Okay, the QRS only comes into play when you are describing the conduction, whether it's normal conduction or not. Okay, so PQRS, and then QRS precedes P, and P is followed by QRS. This indicates you have a normal conduction. Okay, make sense?
Yes.
Yes.
Okay, so in other words, again, you should have a normal P wave axis in order to call an axis being, in sinus, and roughly it's between 0 degrees and 90 degrees, or possibly 1, 2, 3, and AVF. Okay, okay. So now, if you see a P wave, sorry, if you see an ECG, first thing you look at is the P wave axis, and if it's sinus, you're good. If it's something non-sinus, then you should think of course, something that's not sinus. Then you should ask your question: are we tachycardic or are we bradycardic? Okay, are we fast or are we slow? Okay, and then if you are fast, do we have narrow complex, tachycardia, or wide complex tachycardia? Like, is the QRS narrow, normal-looking QRS, or wide, abnormal-looking QRS? And then accordingly, you have differential diagnosis. Okay. And same thing for bradycardia. If you don't have, if you are in non-sinus rhythm and you're bradycardic, you have a differential diagnosis. Okay, so here obviously this is a little bit more advanced, but of course things that you need to know is when you have something that is non-sinus, narrow complex tachycardia, you should always think of SVT or flutter, right? These are common narrow complex tachycardias. Okay. And if you have wide complex tachycardia, you should think of VT, right? Or aberrantly conducted SVTs. But a little bit this is advanced. And if you have a bradycardia, non-sinus, there are escape rhythms that that are usually happening, such as an atrial escape rhythm, junctional escape rhythm, and ventricular escape rhythm. Okay. So in other words, if you see P wave, it's sinus, then then you move on and look, now focus on the PR interval and the P wave morphology. But if it's non-sinus, then you have to ask yourself a couple of questions in order to determine what are you looking at. Okay. Okay. So, for example, this is an ECG where you don't see a very clear P waves, right? I mean, anyone do appreciate the P wave here? Do you guys appreciate a nice normal looking P wave here or no?
No.
Okay.
No.
I mean, there are P waves here, but they are difficult to see, and they're probably here at the end, at the tip of the T wave. Okay, but they are difficult to see, and if anything, they are inverted here in lead one. So this is definitely non-sinus rhythm. This is something fast. Let's say this is at 12 years old, and this heart rate is like 240 beats per minute. So non-sinus, narrow complex, fast. Then you think of your main differential will be SVT, right?
Yes.
Yes.
Yeah. Okay, this is very common. This is regardless of what specialty you go into, you will probably see an SVT, once in a while. Okay, this is very common tachycardia. Okay, and another example here, you see, non-sinus rhythm, right? Because the P wave is inverted in lead one, inverted in lead AVL, which is not a sinus. This is not sinus rhythm. Agree? Despite lead 2 being positive P wave, lead 3 being positive P wave, and here AVF being positive, but negative P wave in lead 1, this means that you have an abnormal P wave axis. In other words, you are not in sinus rhythm. Okay?
Yes.
Right? Or this is too complex?
No, it's fine.
It's good.
No, it's clear.
It's okay.
Okay. Okay. So this patient, actually, these are all our patients. So this patient is roughly an infant. She was around 8 months old, with with left atrial tachycardia. Left because the P wave in lead 1 is negative, so you're going away from the left side. So there's something coming from the left side and traveling away from the left side. So this patient had atrial tachycardia, incessant, difficult to treat, complex patient. But anyways, this is a narrow complex tachycardia, but more specifically, this is called atrial tachycardia. and accordingly she was treated. But anyway, so this is another example of non-sinus rhythm. The ECG on the right side here, you have a P wave that is negative, and this is lead 2, by the way, lead 2 being negative, lead 3 being negative, lead AVF being negative, and it's and let's say this is like a 5 years old, so this is bradycardia for a 5 years old, and you have P wave that is abnormal and negative in the inferior leads. So where do you think the P wave is coming from? Anyone?
Low right.
Good, low right. It's going away from the inferior atrium, and right because the lead 1 is still positive. So it's going away from the inferior atrium, and it's right-sided because the P wave is positive in lead 1. Okay, so this is a low. Oh, so the answer is here, by the way. I don't know whether you looked at this or not, but
Yes.
I mean, it is an advanced question, so I don't expect you to know the answer, but it's yes, low right, because it's low because P waves are negative in the inferior lead, so it's going away from the inferior leads, and right because the P wave is positive in lead 1, which means it's going towards the left side. Okay, makes sense. So this is called an atrial escape rhythm. This is typically in a patient with sinus node disease. You get an atrial pacemakers that take over. Okay, okay. So anyways, we are this is a little bit advanced, but just know if you don't have a sinus rhythm, you have to ask yourself: are we tachycardic? Are we bradycardic? Are we in narrow complex or wide complex? And accordingly, you figure out what this patient rhythm is. Okay, okay. So now, after you know whether the patient is in sinus rhythm, typically, then your next question would be rate. And rate, rate is, there are a couple of formulas to determine the rate of the patient on an ECG. And, and I will not bother you with this. So just, I'm sure you know some couple of formulas, and you just, you'll see this in each and every book, and you should just study it, okay? But an easy one to do is to count the number of QRSs, because the ECG is run over a 10-second rhythm strip, right? So, count how many QRSs you have and multiply by 6. This tells you how many beats per minute there are. Okay? Okay?
Yes.
Yes.
Okay.
Okay. So next, someone said, so now we're still on a P wave, by the way. So now you see the P wave. It's a normal axis. Then you ask yourself, is the P wave tall or wide? Okay, a morphology of the P wave. Because like we said, if the P wave is tall or wide, this indicates you have an atrial enlargement. Okay, so this is an example. Is this P wave abnormal in morphology or abnormal in morphology?
Abnormal.
Right. So this is obviously super tall P wave and wide dish P wave. Okay, so this is roughly 3 small squares. So this is wide, but definitely very tall. Okay, and then there's indentation in the P wave. Okay, so the P wave is, like we said, the atrial activation starts from the right side, right, from the sinus node. So the initial portion of the P wave is due to right side atrial activation. Okay, and then you get left side atrial activation, and so the P wave is combination of both. Okay, so if you have, let's say, pure right-sided atrial enlargement, let's say, so you will get, so you see my laser pointer here, right? So you will, right?
Yes.
Yes.
Yeah.
You will get a huge P wave from the beginning because you have right-sided atrial enlargement, and then somewhere in the middle you'll start to get left atrial activation, but you will have eventually the combination of both would be just one big large P wave. Okay, because you have from the onset you have a atrial disease, right side atrial disease, and you'll get one big P wave. Okay, versus if you have pure left-sided disease, left side atrial disease, you'll get a normal initial P wave, and then by the time the left atrium starts to depolarize, you will get a lot, and the terminal portion of the P wave would be abnormal and large, and you will get, pronounced indentation or bifid P wave because of the abnormal terminal portion of the P wave, and you'll get mainly wide P wave, right? Makes sense? So you'll get here mainly wide, and you'll get here mainly tall P waves, okay? So you don't need to memorize it. It's just all common sense, okay?
Yes.
And then of course, if you have a combination of both, then you'll have biatrial enlargement. You know, it's a sign of biatrial enlargement, okay? Okay. So now you're done with the P wave. So you know the P wave axis and you know the P wave morphology. Next is PR interval. So when you assess the PR, you have four options. You have either normal PR, of course. You can have long PR. You can have short PR, and you can have something called depressed PR, which is a specific, it's a specific finding in a specific disease. Okay. So when you have a prolonged PR, what do you think of? What comes in mind?
AV block.
Hello, AV block. So good. So when you see PR prolongation, then you should think we are in AV block, and then figure out what type we are. What type of AV block it is. Okay. So an example. Obviously long PR, right?
Yes.
Yes.
Okay. So now you ask yourself, okay, we are in long PR. What AV block, and we are in long PR, and then the next question would be, what type of AV block is it? Do you guys know how many types do we have?
3.
3, and the second is divided into 2.
2.
3 degrees.
Right. So let's say this patient, the P wave. I am not giving you the entire ECG, but imagine, imagine this P wave is sinus P wave. So you always make sure it's a sinus P wave. If it's a sinus P wave, the PR interval is long, then you think AV block. Okay. So now, in this case, what type of AV block you think it is?
Type 1.
First
Good.
degree.
First degree.
Which is persistent PR prolongation, right? Good. So you have persistent. You have to make sure that the PR is fixed and steady in interval. Okay. So that's first degree. Okay. Next. So again, you scan through this rhythm strip and you see occasional PR prolongation. Then you think again, we are probably we have to think of AV of AV block. So now you ask yourself what type of AV block it is.
Degree type 1.
Okay.
It's 1 second.
It's one, right? Because there is PR prolongation and then dropped. Okay. So you have to have, again, you make sure you are in sinus rhythm. So imagine this P wave is indeed in sinus, has a normal P wave axis, and then you see PR prolongation at some point. Then you analyze the ECG further, and then in this case you have gradual PR prolongation and block, and then the cycle repeats itself. So this PR is usually similar to this PR, and then this PR usually similar to this PR, and then it blocks. Okay, so this is Mobitz 1. Okay, next. And then you see this rhythm strip again. We are in sinus rhythm, and you see this. And let's say I'm telling you this is a 6-month-old infant. So it's a baby, definitely bradycardic. Okay, you see PR prolongation here. Then you think we're AV block. Okay, what type of AV block is that?
Also second, but Morbid's 2.
Mobitz 2. Okay, why do you say Mobitz 2?
Because the PR is same every time before the drop.
Okay, so but there is a drop P wave, right?
Yeah.
Right. So if you march them through, this sharp deflection within the T wave is unusual for a T wave. Okay, and then if you measure the interval between this deflection and this deflection and with the subsequent deflection and so forth, you will see them coming perfectly. Okay, and so there is every other P wave. It's dropped, and then the P that conducts has a fixed PR interval. So this PR interval is similar to this PR interval, similar to this PR interval. Okay, sometimes this PR interval, by the way, could be normal, but sometimes a little bit on the longer side. So it doesn't have to be abnormal in this case, but even if it's abnormal, even if it's normal, sorry, you'll definitely see more P waves than QRSs, and you think of AV block. Okay. Okay. So in this case, this is 2-to-1 AV block, where in which you have regular PP intervals, regular PR intervals, and identical P waves. You know, sinus usually P waves, and then you have P's that are not conductive. Okay. Okay. And next, you have this rhythm strip again. This patient, let's say in sinus rhythm, and you see at some point, or there's low, prolonged PR here and here. So then you think we're an AV block, and then obviously this is the complete heart block, because the PR interval is all over the place. There's no specific. Of course, you have to look at it at you have to. It's best to have a long rhythm strip, and then you study the rhythm strip, and then you would see that the PRs are all over the place. There's no specific trend. There's sometimes super short PR, sometimes super long PR, sometimes mean normal looking PR, sometimes mildly abnormal looking PR. So the PRs are all over the place, but the P to P interval is always regular, and the R to R interval is usually regular. Okay, and there's more P's than QRSs. So this is complete heart block, in which there is no association between the atria and the ventricle. There is no conduction between the atria and the ventricle. Okay, so you have more P's than QRSs, regular RR intervals, regular PP intervals, and then PR intervals that are all over the place. Okay, make sense?
Yes.
Yes.
Okay. So AV block, if you follow these rules, AV block is easy, but people really confuse them so much because they are a little bit not very organized how to approach the AV blocks. Okay, so it's relatively easy if you know what you're looking at, and if you know how to rule in or rule out each and every one. Okay, so again, now we talked about long PR. So if you see long PR, you think of these four differentials. Okay, now anyone can, any volunteers for in terms of interpreting the ECG, please?
Okay, I will do it.
Yeah, go ahead.
Okay, you can go, sir.
Sorry?
It's fine. Try.
Okay, so looking at the P wave,
Yeah.
it looks the axis is normal, so it is the sinus P wave.
Yeah, so positive here. You don't see it well, but I agree with you. It's probably positive. Okay, next.
Yes.
It's probably sinus.
The PR interval looks shortened.
Okay, so which is
And
around
there is
50 milliseconds, right? Or 80 milliseconds.
and
Okay.
there is I think delta wave.
Yeah.
Pre-excitation wave.
Yeah. Okay, so you have WW, delta wave, pre-excitation, normal sinus rhythm. Anything else? Let's say this is a 14 years old, by the way.
The QRS is a little bit wide.
Okay, wide QRS. What else? Any help?
And
Someone can.
the QRS.
Yeah.
The QRS in the second NT2 is abnormal.
In lead 2, okay. You mean it looks abnormal?
Yes.
Okay.
Low amplitude.
Sorry, what did you say?
Low amplitude.
Low amplitude. Okay. Anything else? So again, we said you need to have a system. So you talked about the P, you talked about the PR. Now you're focusing on the QRS. We didn't talk about the QRSs yet, but this is definitely, this is it a normal QRS axis or abnormal QRS axis?
Abnormal.
Okay, good. So you have abnormal QRS axis. Okay, so yes, you're right. So there is WBW. Okay, there is short PR. Okay, so you guys know why do we have delta wave in WBW? Like why? Like what does this delta wave, means? Do you guys know?
Early activation of the ventricles bypassing the AV node.
Good. So you have your sinus node again here. So usually the electrical activation goes down to the AV node, right? So now you have an accessory pathway, which is like another AV node. However, this another AV node, conducts electricity rather quick. During an AV node, it usually the conduction is a little bit slowish normally in AV node, okay? But in this accessory pathway, usually it's rapid, okay? So often you have an area of the myocardium here that is activated before the His-Purkinje system activates the myocardium. Makes sense? So this area, because it's activated not synchronously through the His-Purkinje system, it is inefficiently, activated cell by cell, and then so you have a wide, delta-looking wave that is, at the onset of the QRS. Okay, and then once the QRS sharpens and rapidly deflects up and down, this is when the QRS is activated by the His-Purkinje system. Okay, so onset of the QRS would look abnormal, and then it normalizes. Make sense? So because of the onset being abnormal, you will get a wide-ish QRS because of the onset. Make sense? And because this access pathway conducts rapidly, you will get a short PR, because usually, again, we said the AV node a little bit slows down the conduction and you get a decent PR. But if you have an accessory pathway that conducts quick, you will have shortening of the PR. Makes sense? Because the PR just means the time that it takes for the atria to activate the ventricle. Okay, so the time that it takes for the atrial depolarization to activate the ventricle. Okay, so if you have an accessory pathway, this time would shorten. Make sense?
Yes.
Yeah?
Yes.
We have short PR, delta wave, and wide QRS.
Yes.
Okay, and also because normally the QRS axis is between 0 and 100 degrees, because the ventricle, the ventricles are the heart is positioned on your left shoulder, chest, and the left ventricle being a little bit more posterior, right ventricle being a little bit more anterior, and the vector of the electrical activation is going towards the left. Okay, so when you have going towards the left and inferiorly, because you're going this way. Okay, so but when you have another competing vector from the accessory pathway, this axis may differ, and then often you have an abnormal QRS axis in WW, not because the heart is just diseased, just because of the accessory pathway changes your QRS axis. Make sense?
Yes.
Okay, so often with WW you get wide QRS and you get abnormal axis, and then for example here these are all like negative deflection QRS, and then when you see this, often you worry about a scar, right? You worry about this patient had an inferior infarction, for example. Because you have scars, Q waves in the inferior leads, but this patient has WW, and hence the appearance of the QRS, not because the patient had an inferior scar. Okay, so when you have WW, it really messes up your ECG, and but everything would be back to normal once the access pathway goes away with ablation. Okay.
Okay.
Make sense, or this is difficult?
Makes sense. Yes,
Makes
makes
sense.
sense.
Okay, so we talked about long PR, we talked about short PR. We said there's something called PR depression, which is a sign of pericarditis. It's not very arrhythmic, of course, so it's a very specific finding, and just know that the PR depression is often a sign of pericarditis. Okay, so we're done with the PR, right? So what is the what's next after the PR is the Q wave. So the Q wave is a very special wave within the QRS, of course, and hence why we're focusing on it. So Q wave could be, so there are normal Q waves and abnormal Q waves, or pathological Q waves. Okay, do you guys know what Q wave represents. Why do we, why is there, first of all, what is the definition of Q wave? Do you guys know?
The
Anyone?
first negative deflection in the QRS.
Perfect. So that's the definition. And do you guys know where it is typically found? In which lead, I mean?
Left pericardial
Right
and AVX.
Okay, left and inferior. Excellent. Okay, so the Q wave, and you guys, the Q wave is since it's the beginning of the QRS, it represents the initial ventricular depolarization, which is the septum. Okay, so remember the AV node, once it's activated, septum is right there, right? So the septum is activated first. Okay, and the septum is activated usually from the left to the right, left side of the septum to the right side of the septum. And remember, the heart is positioned this way, right? And we said left ventricle is more posterior and right ventricle is more anterior. So the left, so the septum is activated from posterior to anterior, from left to right. So you see Q waves in the inferior leads and the left leads, okay, usually, okay? Because again, you're going away from the left leads and you're going away from the inferior leads, okay? So, so often you see Q waves in the inferior leads and left leads, and however, this Q wave should be very skinny, should not be very wide. At 0.75 or at or 75% or maximum one small square. If it's more than one small square or 75% of one small square or 0.75, then this is a wide Q wave, and then it's a pathological Q wave, and then you have to think, are we WW or are we having infarction? Okay, so you have to think of other things. Okay, if you see wide Q waves, then think of other things. Okay, and you have to, of course, worry about infarction or something else, and then you have to investigate accordingly. Okay. 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 So QRS is Q wave is very important wave. You should not miss a wide Q waves, okay? Because again, it could be very significant. Okay, so now QRS. So QRS is similar to P wave. You focus about the axis of the QRS and the morphology of the QRS, okay? In terms of morphology, what morphologies do you know of QRSs?
RSR.
Okay, good. RSR. In V1, right?
Yes.
Right? RSR in V1, right?
Yes.
So, what does this mean?
It means right bundle branch.
Okay, good. So, again, ECG in general is all, there's no memorization in it. It's all understanding. So the reason why you get RSR prime in V1 in right bundle, because like we said, the septum is depolarized left to right. So when you have right bundle branch disease, your initial septal depolarization is still intact, still normal. So you still get left to right septal depolarization, and V1 being an anterior right-sided lead, you will get initial R wave that represents your septum, okay? And then once the erectile activation travels down the septum all the way to the apex and the left, and then the ventricles, of course, you have right bundle branch disease, so you will get left-sided activation unopposed. Usually they are activated roughly the same time, but now because you have only your right bundle is diseased, you'll get unopposed left-sided activation and you'll get S wave. Okay, so you'll get S wave in V1 because the left started to activate, and then your right ventricle is activated inefficiently because you don't have a normal right bundle, so you will get a delayed, wide, big terminal QRS. So you'll get R, S, and R prime in V1. So you'll get terminal conduction DNA, or you get terminal QRS disease or delay on your ECG, on your QRS. Okay, so this is a sign of right bundle branch block. Okay, so you get RSR prime in V1 or slurring of the S wave in V6. Okay, so you have terminal slurring or terminal slowing of the QRS. Okay, and then when you have left bundle branch block, you'll have disease QRS throughout because your onset is from left to right. So your septal activation is even abnormal. So you'll get wide QRS and slurring of the QRS and widening of the QRS because of your diseased left bundle. Okay, so if you have RSR prime in V1, this is right bundle branch block, and this is the commonest bundle branch block that you see in pediatrics. Of course, left bundle branch block you see more in adults. Right bundle branch block is usually secondary to repair, cardiac repair, and hence this is why you see it often in pediatrics. So left bundle is more ischemia, and we don't see as much ischemia in pediatrics. So focus on right bundle branch block, and this is how it looks like. Okay, so and then access, you guys all know access, being positive in lead 1 and AVF, and in 2 and 3 and AVFs all should be positive, and this is normal access. Okay, like a P wave. Okay. Okay, and then if it's elsewhere, of course, then you get accordingly, your axis changes and, right axis or left axis and so forth. Okay. Okay, so QRS is easy. Next would be after your QRS, of course, your ST segment. And in ST segment, you can have normal ST segments, of course. You could have elevated ST segments or S segment elevation or ST segment depression, right?
Yes.
Right? So if you get a segment elevation or depression, what do you think of typically?
MI.
Hello, ischemia, MI, and so forth. Okay, which is not very commonly seen in pediatrics, but still happens. Okay, so however, there's something called early repolarization, which is a non-pathologic ST segment elevation that is seen in young, healthy individuals. Okay, so this is an ST segment elevation that is normal or benign, usually seen in lateral and inferior leads, and usually there is T wave ST segment concordance, meaning if you get this ST segment elevation, the T wave is also elevated. If you have ST segment depression, the T wave is also depressed or inverted, sorry. So, for example, here you have minimal a little bit of a segment elevation and T wave that's upright. Here you have a segment elevation and T wave that's upright. Here you have a segment depression and the T wave that is inverted, and normal appearing T wave, And also the patient is healthy, he's not complaining of chest pain, troponins are normal, and you did an ECG as because you are screening him for something. Okay, so you are not suspecting ST segment, you're not suspecting ischemia, and the patient is young and healthy and usually very healthy, athletic, and you see such ST segment elevation is often early repolarization, which is normal. Okay. However, if you see discordance between the ST and the T wave, then you should think of true pathologic ST segment elevation or depression. So for example, here you have S segment depression with T wave being upright, that discordance. You have here S segment depression, T being upright, discordance. You have here S segment elevation with T being flat or flattish, that's discordance. So of course, and the patient describes a typical chest pain, or he's at risk of coronary artery disease for some reason, or it's exertional and troponins are high, then of course you should respect this finding and rule it out or rule it in. Okay, and usually if it's true a segment elevation, it usually follows a specific coronary artery distribution. Okay, so for example here you have a segment changes in the left lateral leads and inferior leads. Okay. And here you have a segment depression in your in your V6 and V5 and lead 1 and lead AVL. Okay, so left leads. Okay, so again, a segment elevation, you have to make sure it's and then here, for example, like we said, there's a segment elevation and T wave that's inverted. That's abnormal, right? Here a segment depressed and T wave that's upright, abnormal, right? These are not early repolarization findings, okay? Okay, guys?
Yes.
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 Okay. Okay. So now we're done with S2 segments. Now next would be QT. And I'm glad that someone, at the onset of this presentation, someone mentioned to measure QT because it's a really important something, of interval to measure, because you guys heard of long QT syndrome, right?
Yeah.
Yes.
And what is
Yes.
the worry about long QT syndrome?
Can convert into ventricular fibrillation.
Right. So,
So the,
SADs and sudden death and polymorphic VF, okay, polymorphic VT and VF, okay? So this is an example. This is one of our patients who was, had frequent syncope at home, and, this is his ECG. He has, super long QT, and if you measure it, it's like around 600. Okay, this is super long QT. This is a very dangerous finding, and this patient is lucky to be, to survive his frequent syncope. He probably had non-sustained VF, okay, or TURSAT, okay. So obviously sometimes it's not that, sometimes it's very subtle, like there's minimal QT prolongation, and so you have to not to miss it. This is very obvious, but sometimes not super obvious, and you have to get into the practice of measuring QT, and if it's abnormal or borderline, to confirm it with someone who's experienced with ECG, okay? Makes sense, but this is obvious that to your eyes, you guys are aware, it catches your eye that we are in very long QT interval, right?
Yes.
yes.
I mean, typically the RR interval, 50% of the RR interval, which is here, your T wave should end before the 50% RR interval, like half the distance between the RR interval, your T wave should end before, typically, So this is definitely way beyond the half, 50% of the RR interval, okay? Okay, so the next would be T wave, and T wave is a little bit dynamic, meaning at birth to 1 week of age, the T wave is upright in precordial leads, and then it inverts on right-sided leads, and then it's upright again at roughly 7-8 years of age and onwards. Okay, so the T wave a little bit changes with according to age, so you have to be aware of this. Okay, and of course, if the T wave is flat or negative in somewhere where you would not expect it to be negative, then this could be a sign of ischemia and stuff. So T waves should be upright in general, except in AVR and or specific ages. And if they are negative, then you have to make sure we're not talking about ischemia. Okay. Okay. Okay, so T wave is negative in, like we said, in pediatrics often, but then usually it becomes back upright just before, 8 years of age or so, just after 8 years of age or so. Okay, okay. So, so finally, you need to know roughly, what are the normal value ECG values in general. This is not, it's not for the exam purposes. I mean, it's just in general. You need to know roughly what's the definition of P being, P wave being wide or tall. What's the PR intervals in general? Rough idea. What's the QRS intervals in general? Rough idea, so that are we talking, abnormal or normal? And then be aware that when you have wide QRS, okay, or abnormal depolarization, let's say you have right bundle branch block, so you have an abnormal QRS, and hence whenever you have abnormal depolarization, the repolarization would also be abnormal. Okay, so when you have abnormal depolarization, everything else that is subsequent to the depolarization gets abnormal. So when you have a right bundle branch block, for example, your axis may change, your voltages would change, your S segment would change, your QT would change. So this messes up your ECG, and it would be difficult to interpret the ECG in terms of axis voltage, SC, and QT. So you have to be careful about this. Okay. I get so many phone calls in a patient with right bundle and SC segment elevation, but this right bundle often, it's usually when you have right bundle branch block, your ST segment would change, and then it's difficult to interpret that ST segment elevation as being, ischemic. Okay, so you have to, rule out ischemia by other means, like for example, CT, echo, good history, labs, and stuff. Okay, and so forth for like QT and everything else. And then there are artifacts that are very commonly seen in pediatrics, and you have to be aware of. Okay, and sometimes you see low voltages, and of course, this could be a sign of pericardial effusion, pleural effusion, or just big chest wall, or cardiomyopathy. So pay attention to the voltages and whether they are low or normal. Okay, we always pay attention to high voltage, but sometimes low voltage is also not good. Okay, so ECG, at the end of the day here, ECG is relatively easy. It just needs practice, and the more you're organized, the more you have a system, the easier it gets. Okay, the more you know what, if you know what to look for, then you'll be able to identify it. If you don't know what you're looking at, then of course you will not be able to interpret an ECG. Okay, so questions. Guys, questions?
No questions.
It was clear.
Yeah. Cool. No questions. Okay. Was it relatively easy or appropriate or hard or?
I think easy.
It is appropriate.
So AV blocks. You have to you need to know AV blocks. You need to know SVTs and flutter, maybe VT. These are all medical student level ECG findings. Okay.
Yes.
Okay. Let me. Okay. So I think we're done. I don't know how to. Let me just stop the recording here. Stop recording.